Good. Jimmy, thank you for that generous introduction. I'm going to be talking about what's new in Alzheimer's. It's the custom at Grand Rounds often to mostly present your own work and show how your trajectory is fitting in with the larger field. What I thought I'd do is the reverse. I want to talk about what's new and interesting, and then my own work will appear here and there like raisins in a raisin cake. I just think there's a lot going on, and I'm not the center of the universe. I'm just one of many people in this field. Summary and agenda. I don't need to tell you, Alzheimer's disease is a big public health problem. I'm going to focus on four areas: diagnosis and blood-based biomarkers, treatment of neuropsychiatric symptoms, which is very much a Hopkins specialty, some of the new treatments targeting disease modification. You've probably read about these in the news. And I think the most important is lifestyle strategies to prevent Alzheimer's disease. It's hard to sum up everything in a slide, but basically we like to think of amyloid, tau, and neurodegeneration as kind of three major steps in the early Alzheimer's pathway. Amyloid is deposited at least 20 years before the first symptom. These are senile plaques, which are dense aggregates of amyloid monomers. I'll show you a slide with some of the cartoons of the metabolism. And amyloid beta comes in two forms, 42 amino acid and 40. 42 is more likely to aggregate. The main thing you should know, by the time someone comes in with the first symptoms of dementia, they've maxed out their amyloid pretty much. Tau comes next. These are abnormally phosphorylated tau that forms neurofibrillary tangles intracellularly, interferes with microtubule assembly. As you can imagine, axons desperately need microtubules to work because they're very long. They have to transport all kinds of chemicals from one end to the other. Tau spreads around the brain in characteristic pattern. They call them Braak stages on autopsy. And our imaging actually fits very nicely with these. You got to have tangles to have symptoms. Neurodegeneration seems to come after amyloid and tau. So we've got the ATN model. And this means neuronal loss in the hippocampus and posterior cingulate. Then there are several downstream mechanisms which are important, but which we know less about treatment, including inflammation, oxidative stress, and brain vascular disease. So these probably happen after the A, T, and N, although vascular disease is probably an ongoing process throughout. Some slides from NIH with pretty pictures. Here's a slide showing the extracellular beta amyloid plaques. They're very dense. You actually have to dissolve them with formic acid if you want to measure them. And so you see they're extracellular. Whereas here, you got these neurofibrillary tangles, which are twisted tau fibers that build up inside the nerve cell. And I can talk a little about our current biomarkers for amyloid. We have amyloid PET. I'm so sorry, I'm having trouble with my PowerPoint. We have amyloid PET, which is not covered by insurance for the most part. CSF amyloid is decreased. There's the plasma A beta 42 to 40 ratio, and plasma phosphotau is increased. I'll get to that on the next slide. Amyloid seems to be necessary but not sufficient for clinical disease. Measuring tau, we do have clinical tau PET, also not covered by insurance, but CSF tau is a pretty dependable biomarker and is increased. So amyloid is decreased in CSF, probably because it's being deposited in the brain. Tau is increased. And plasma phosphotau is increased. And I'll get to that in a second. Neurodegeneration is not specific to Alzheimer's, includes brain volume loss, hippocampal volume loss, and a really nice plasma biomarker, neurofilament light. And these reflect neuronal loss and very much not specific to Alzheimer's. It's seen in most of the dementias. So here's some PET. Here's a 75-year-old woman with Alzheimer's dementia. She has very elevated tau, a very, very elevated amyloid on PET. As you know, with PET, the bright colors tend to be more uptake, and the darker colors are less uptake. And she's got amyloid all over the brain. This woman has early dementia, but the amyloid is maxed out. She also has tau all over the brain. It's spreading out along the lateral temporal cortex. And if you see this little peanut here is the hippocampus, And on both sides, the little peanut is surrounded by dark space, which is CSF. There's a lot of fluid and a small hippocampus, and that reflects hippocampal atrophy, which we can measure. And if you get NeuroQuant, you can actually get a quantitative measurement of hippocampal volume. It's a great positive biomarker. It's not a great negative one because you can miss a lot. The main thing is there have been huge methodologic improvements in blood-based biomarkers. I showed you mostly CSF and imaging. For many years, they correlated poorly with disease, and now there are much more sensitive assays that correlate very well. It's mostly the last 2 to 3 years. The A-beta 42 to 40 ratio correlates well with brain amyloid, and there is a clinically available test, Procivity. It actually combines this ratio plus ApoE with an algorithm to predict amyloid in the brain. It works very well, and it's being widely used in research to screen who needs an amyloid PET. It's not covered yet by insurance. It costs $1,250, although if you're writing a grant, about $200. The most amazing thing has been that phosphorylated tau correlates with brain tau and brain amyloid. It correlates with the biologic mechanisms of Alzheimer's. It's been just fantastic. Of course, there's an arms race between different epitopes that are phosphorylated. 181 is good. 217 has a larger signal-to-noise ratio. 231 may be the first to increase in people who are normal. But the main thing is these correlate well not only with PET amyloid and tau PET imaging, but they really correlate with the clinical course of disease. Similarly, the assays for neurofilament light have dramatically increased, and as I said a couple times, it correlates with neurodegeneration. So if you've got an elevated A-beta 42 to 40 ratio, if you've got elevated phospho-tau, you may be on the Alzheimer's pathway. If you have elevated neurofilament light, you probably have neurodegeneration. It was difficult for me to find a pretty slide that would fit this here. So this is an ROC curve, and what I can show you here is that this would be the random chance curve. This purple one is if you use just phospho-tau 217, and these other ones are if you add things like cognitive tests and MRI scanning. But with pure clinical measures, you can get a pretty good AUC. Look, here's a AUC of 0.81 for P217 alone and 0.89 if you add cognition. So we're not that far from a blood test for Alzheimer's, but why aren't we using it yet? Well, the main thing is we got to get more normative data in real-world populations. Most of this work has been done in highly refined research cohorts. So we're just starting to get to the cutoffs. The first thing is, which phospho-tau variant? As I said before, if we're going to look into normal cognitively unimpaired populations to do prevention at the earliest stage, p-tau 231 is probably the best, but 181 and 217 appear better for differential diagnoses. The main thing is there are confounds. One of the main ones is poor renal function. Our colleague Michelle Milkey, who used to be in the department with the office next to mine and is now chairman of epidemiology at Wake Forest, she's done a lot of work with the Mayo Clinic population. And for example, the very highest value she's ever seen for p-tau 217 was in a patient whose autopsy definitely showed no Alzheimer's pathology, but who had a creatinine of about 3.7. So we really are going to have to do major adjustments. My guess is we'll be using it clinically in 3 to 5 years, and the A-beta 42 to 40 ratio is available right now. The other one's probably next year, but it will depend on insurance coverage. So keep your ears and eyes open on this because it's a very exciting development. I'd say it's been really, the field's turned around in terms of diagnosis in literally 2 years. Neuropsychiatric symptoms. This is why one of the reasons a psychiatrist studies Alzheimer's. And I'm going to focus on apathy and agitation because I'm the drunk looking under the light where his grants are focused. No, seriously, this is where I've done the most research, so I would talk the most about them. So the main thing is, we all know Alzheimer's is much more than a pure cognitive disorder. It affects emotions, it affects mood, and affects social relationships. And these psychiatric symptoms are a major source of stress and burden for patients and caregivers. Of course, behavioral strategies are first-line treatments, but they are hard to codify. It's been hard to come up with a textbook or a cookbook for them. We're having some increasing success with drug treatments. Costas does a lot of work on this, of course, and we like to call this the low-hanging fruit of Alzheimer's treatments. In other words, we can reduce burden right now while the field as a whole is looking to cure the disease. There's different acronyms. We like neuropsychiatric symptoms. Some people use behavioral and psychologic symptoms of dementia, BPSD. They mean the same thing. The neuropsychiatric inventory is a widely used instrument. It was devised by our friend Jeff Cummings in 1994. It's been surprisingly sturdy. You can read the different lists, the list of symptoms here, and just suffice it to say, it overlaps a lot with your non-demented psychiatric disorders, but there are some that are particularly common in dementia. Agitation, it's a huge range of behaviors. It's disturbing to caregivers. It's often worse in the evening, and we call it sundowning, but we don't really know that it is a disordered circadian rhythm. I don't have any data to show you yet, but I have an R01 to basically look at this, comparing actigraphy and sleep studies in patients with Alzheimer's who have agitation or no agitation. I want to see if the agitated patients do have a disordered circadian rhythm. Agitation can be, of course, associated with delirium, and just a few adverbs here. They could be pacing, shouting, catastrophic reactions, beseeching, help me, wandering, but the list goes on. And of course, being physically combative tends to be the worst part. My main point to you, before you treat, define your target. International Psychogeriatric Association criteria for agitation in Alzheimer's disease. People were trying to define it so we could study it better. And a group got together, and in the IPA journal, International Psychogeriatrics, they came up with provisional criteria. You got to have dementia, either 3 domains: excess motor activity, that means like pacing; verbal aggression, that means yelling or cursing; and physical aggression, that means slugging people. And when I talk to families, I often say, well, does he hit you? Does he slug you? The behaviors have to be severe enough to produce excess disability. This really means they are causing distress or problems, and they're not attributable to something else. I happen to be fortunate enough to have been asked to join. These are provisional criteria, and we're working on the final criteria. We essentially came out with a more detailed and long list. And what we discovered was we didn't need to change the basic content very much. We did a widespread poll of experts in the field, and they liked the basic content. And now we're trying to identify special circumstances that require some more targeting and to create a care algorithm, which will always be controversial when it comes to the drugs. Common causes: it can be delirium, which is often from a medical problem like a UTI, or from medications, especially anticholinergics, benzos, and opioids. It could be from the cognitive impairment itself, especially disorientation. People become agnosic. They don't recognize what's in front of them. They don't recognize what the visual stimulus means. They may become very upset. This is the woman, she's lived in the same house for 50 years, and at 5 p.m. she starts yelling at her husband, "Take me home!" And she's lived there for 50 years. The familiar can become unfamiliar. People may become frustrated with functional deficits. It might be a recurrence of a prior illness, such as major depression or psychosis. More commonly, it's a depression or psychosis caused by Alzheimer's, and a substantial proportion of demented persons have significant mood disorder. Environment: they may become agitated because they need a different level of care, usually more supervision. Or you may have changed their environment. I mentioned before, people become easily disoriented if you move them. Or unsophisticated caregiving. Trust me, it's just as likely with people you pay as with family. And so we've been we've been trying to codify for our paper some of the things you can do behaviorally. And I don't have time in this talk to really sum it up, but planning activities, adjusting the environment, helping the care partner, such as the family, take care of themselves, communication strategies, particularly in advanced dementia, realizing that language may not work. Your communication may be mostly nonverbal. Patient-directed, especially physical exercise. Music, among the many modalities of therapies that they do, music therapy actually has the best track record, and it's probably, I think, because people often retain the ability to process music where they cannot process language. I'm biased. I'm an amateur musician, a jazz pianist, so I think it's great. And I'm working with Fred Barrett, Alex Penteliot, Kerry Devlin on a little study to see if music therapy alters brain mechanisms of listening to music. Okay, medications. So nothing is yet FDA approved. Everything is off-label. So let me talk about what we're using off-label. SSRIs, we think, are the safest, not necessarily the most effective, but we had a pretty good efficacy and safety for citalopram in a multi-site study. And now I'm helping Costas out, who's the PI, on an NIH-funded trial of escitalopram, that's Lexapro. That's because we found when the good effect of citalopram was mostly due to the Lexapro component. People are trying mirtazapine, but there was a recent null trial. Antipsychotics, well, atypicals, they're no longer that new, are best tolerated. I put in some typical doses. I have not moved much beyond to newer agents because metabolic symptoms are really quite unusual in frail demented people. And some new drugs, I'm going to talk about these. Anticonvulsants are hit or miss because they also have a lot of side effects. Depakote is most widely used. And I'm going to mention cannabinoids that I'm working on, prazosin and dextromethorphan. Doctor, why are you giving my mother a drug that will kill her? There is a small, I think, a small mortality risk from antipsychotics. This is our friend Lon Schneider's landmark paper from 2005 basically showed it has a relative risk of 1.65 of mortality in a 3-month trial. And it applied to all of the atypicals, and it certainly applies to Haldol, and we're not sure. We don't really have data on newer agents. This does not cause me to refuse to use the medicines, but it causes me to be quite parsimonious. They're rarely first-line agents. When I'm giving them, I'm sorry I didn't write out all the numbers here, I say to families, in a 12-week trial, your loved one has a 3.5% mortality risk. That's a lot for 3 months. If they're on placebo, it's a 2.3% mortality risk. That's also a lot for 3 months. And families usually thank me for the numbers and ask me to make their loved one comfortable. I would say, I think the doctors probably have more qualms than the patients, but I think informed consent is essential since there's an FDA black box warning on these agents. Just a couple details about the citalopram trial. There's no mortality signal. There's a worry about prolonged QT intervals. And I didn't write out the numbers, but we had significant risk. We had 40% response in the citalopram group, 26% in the placebo group, and on other measures we had a more impressive response. So we're out in the field now with escitalopram. THC for agitation and Alzheimer's. Cannabinoids have notable anxiolytic effects, and the CB1 receptor is widespread in the brain. Dronabinol is FDA approved for anorexia. It's not an illegal drug. It is synthetic THC, and it's an analog of THC, the most potent cannabinoid in marijuana. Adverse events include sedation, intoxication, and seizures are quite rare. My good friend Brent Forrester at McLean Hospital had a case series of 40 patients with many good responses, some sedation. Mean dose was 7 milligrams. That was quite inspiring because it looked pretty safe. I'm a crunched author on a randomized controlled trial from the Netherlands. The dose was 4.5 milligrams daily, and the effect was null, and we think that dose is quite low. Sorry for the pun, although I knew Jimmy would appreciate it. There's a high level of interest in this area. So we're doing a randomized controlled trial of dronabinol, 2 sites with some subsites, a 3-week trial. Why 3 weeks? Because we were starting with inpatients, and we just couldn't do a longer trial in inpatients. And now we've moved to outpatients. There is no bottom to the mini-mental, and we have people with very impaired, who are very, very advanced dementia. And in fact, for those folks, we're using a short version of the severe impairment battery for cognition, because when a mini-mental is below 5, it's like 0. Our target dose is 10 milligrams, and we're looking at usual adverse events. We are 62 patients into our targeted 80 patient trial, and we are on our second year of no-cost extension, so it takes a long time. And COVID hit us really hard for this trial. My colleague, Krista Langto, works in Canada and is more efficient than me. She used a Canadian version of THC. She did a crossover trial in nursing homes. It was effective against agitation. Sedation was pretty common, but they could deal with it by cutting down on the dose. Other drugs, just a potpourri. Pimavanserin is FDA, it's a pure 5-HT2 antagonist, and FDA approved for psychosis and Parkinson's. Might be useful for agitation and Alzheimer's. They were recently turned down for a broad psychosis indication. Long FDA story. Probably was appropriate to turn it down. Brexpiprazole is, I believe, an aripiprazole metabolite, FDA approved for schizophrenia. We recently consulted to the company, and they showed us their publicly available data. And there's some promising data. They had a very significant result, but they did not have a very large effect size. So we are a bit blasé about whether this will be a great drug. But other people are using it. In Canada, it's easily available, and our colleagues say it works well. Mirtazapine, sorry for the typo, Remeron, our colleague Shubhi Banerjee, our friend Shubhi Banerjee in Brighton, United Kingdom, and has a negative trial for agitation. AXS-05, it's a dextromethorphan bupropion combination. It's pretty similar to Nuedexta, which is a dextromethorphan quinidine combination. They have promising data in agitated Alzheimer's patients. I think it might well be a good drug. It's in some kind of regulatory limbo at the moment. Prazosin, our friends Elaine Peskind and Murray Raskin at University of Washington have been studying this alpha-1 antagonist essentially for impulsivity and anger. They've had pretty good results in PTSD, and I'm not so hot on their results in agitation. Might be work. It's surprisingly safe. I mean, it's an antihypertensive, but it's a lousy antihypertensive, and you rarely see hypotension using it in this context. I don't expect you to digest this, but if you what I show you here, but we on the IPA committee have attempted to put together an algorithm. We know this is going to be extremely controversial. You do psychosocial care for everyone with agitation, and then we have some specific suggestions for sundowning, such as trazodone, or even a dual, whatever the dual option, dual or acting orexin antagonist. For mild to moderate agitation, citalopram, perhaps another SSRI. For moderate or severe agitation, you might try an antipsychotic. You might try an anticonvulsant. They mentioned gabapentin. I'm helping write a gabapentin grant right now because it's a pretty safe drug, not used much around Hopkins for agitation, but used elsewhere. And then you may go farther along, prazosin, THC, and so forth. And if there is danger of harm, you may need IM antipsychotics. And there is actually some evidence for ECT for very severe agitation, very rarely done because the patient can rarely consent and you generally need to go to court. But my friend Brent Forrester is also doing an ECT study. So there's a lot of options, but not all of them have strong evidence yet. Some do and some don't. We're not there yet. Apathy, loss of interest, motivation, drive, emotional unresponsiveness, usually not associated with neurovegetative symptoms. It is the complainant is the family, not the patient. And it's common to many neurodegenerative diseases, including Alzheimer's, Parkinson's, and frontotemporal dementia. It's very different than depression. You'd think there'd be a lot of overlap, but actually in one of our studies, we found about 10% of the patients had major depression. So we were able to identify a large group who were apathetic and did not have major depression. And I've been part of another consensus group to define the apathy syndrome, and suffice it to say, decreased initiative, that means decreased interest in starting activities, decreased interest in those activities, and decreased emotional expressiveness. And you have to have 2 of the 3 two of the three to call you apathetic. I think we call it a 2-week, so we called it a 4-week syndrome. Let me skip this. It very possibly involves dopaminergic and noradrenergic deficits. Poor initiative is associated with lower dopamine transporter binding in the putamen. There are dopaminergic and noradrenergic circuits between the basal ganglia, anterior cingulate, and frontal cortices involved in motivation and reward, and we hypothesize are dysfunctional in Alzheimer's patients with apathy, and apathy in Alzheimer's was associated with a blunted subjective response to dextroamphetamine challenge. So sort of a hint that it's dopamine and norepinephrine involved. I've been fortunate enough to be a multiple co-PI for 2 multi-site studies of methylphenidate for apathy, and it was effective in both studies. This is the NPI apathy score, and it's the change from baseline. So the better, the more you decrease, the better it is. And methylphenidate, it was a 6-month trial in 180, it was actually 200 patients. And there was quite a spread at 6 months between placebo and methylphenidate. The methylphenidate patients did better. And just to do a survival analysis, if you looked at who had no apathy, sorry, these are reversed. The methylphenidate patients were more likely to have no apathy. We published in JAMA Neurology last year. And we are, because this is good response, but I can tell you it's not everyone who responded. Our next study is going to be a study of who is a responder. We're going to look at biologic markers, including dopamine imaging, like dopamine receptor and dopamine transporter, and also resting state functional connectivity. Okay, those of you who read the papers, and that means all of you, know there have been new drugs out there for Alzheimer's. Let me show you my cartoon. Here's the amyloid precursor protein, which can be metabolized by alpha secretase to a 40 amino acid, and then by a gamma secretase. If you go alpha first, you get a 40 amino acid amyloid. If you go beta first, you get a 42. And therein lies all the difference. These monomers can form oligomers, which are probably synaptotoxic, 2 to 12 repeats, and then they can conglomerate into insoluble extracellular plaques. The function of APP is unfortunately unknown, and you'll see why it's unfortunate. But there are autosomal dominant versions of Alzheimer's that are caused by a single base pair change in the APP gene or in one of the gamma secretase genes. The A-beta 40 is less likely to form plaques. That's good. And the 42 more likely to form plaques. That's bad. A gamma secretase is in both pathways. Amyloid monomers, as I said before, probably start 20 years prior to symptoms. And amyloid beta is decreased in CSF, probably because it's being deposited in the brain in the form of plaques. Oligomers are probably responsible for dysfunctional neuronal function and synaptic dysfunction early in the disease. And the amyloid PET picks up the senile plaques. So how do you cure Alzheimer's? Show me. There's been a lot of work done on beta secretase inhibitors, which seem to be very specific to Alzheimer's disease. However, in the year 2019, and these were very difficult drugs to develop chemically. It took like 15 years to develop them from getting the concept to actually having them in people. People did worse on the drug than on placebo. It was really very disheartening. Gamma secretase inhibitors, a little bit less specific to Alzheimer's disease. Once again, in some of these studies, drug has been worse than placebo. So really baffled these enzyme inhibitors so far are not doing very well, and we've been baffled why patients are harmed by them. Okay, you know if it has an AB, it must be an antibody. Aducanumab, donanemab, lecanemab. These are antibodies that target amyloid oligomers and fibrillar plaques. These particularly target plaques. Decreased amyloid, with aducanumab, decreased amyloid burden was associated with better cognitive functional outcomes. There was a high rate of imaging abnormalities. I'm going to show you that on another slide. And one of the studies was quite positive, with aducanumab called eMERGE. A similar study was null. You guys may be, some of you, certainly Jimmy, privy to the discussions both within and outside Hopkins about aducanumab. The FDA approved an accelerated approval in June 2021. CMS and Hopkins CMS rejected for reimbursement. In January, Hopkins leadership rejected for formulary, and the European and Canadian versions of the FDA also rejected. However, there are two similar antibodies in various stages of development, donanemab and lecanemab. Both of them show similarly promising phase 2 results where you lower amyloid and you get better cognition. I'm going to show you a slide on lecanemab, which came out last Tuesday, and it's being used in a prevention trial. We are a site for this prevention trial. So this was the positive aducanumab trial, the one of two trials, and this was the positive one. And high-dose aducanumab was associated with a slower rate of reduction in mini-mental. Doesn't really knock your socks off. There's a year and a half, and you're less than a point difference in mini-mental, but it was statistically significant. And combined with its robust effect on amyloid, I think that's what pushed the FDA for approval. I think they're quite sorry about that, actually. Donanemab is from Lilly. The drug targets something called pyroglutamate modified plaques. Pyroglutamate is found only, modified amyloid is only found in plaques. And they found a statistically significant effect on a cognitive measure, kind of a newer popular measure, IADRS, with a somewhat more robust signal, I think, than aducanumab, and extremely robust reduction in amyloid. Look at this. You start at 0 and you ask what's the they call it centiloids. It's a lot like percent. They call it centiloid change in placebo. No difference over a year and a half. Donanemab, it was almost all gone. Sorry to use bad metaphors. It was like a vacuum cleaner for amyloid. 80% decrease. And they're going to be announcing phase 3 results, I think, later this fall. Just wanted to mention the clinical dementia rating scale. This is the commonest measure for looking at cognition and function. It mixes up cognition and function. And you go from 0, which is none, questionable, 0.5, 1, 2, 3. And all these studies are being done with patients who are 0.5 and 1, because we basically believe by the time you get to more advanced dementia, it's way too late to improve anything by removing amyloid. But here's the thing I wanted to show you. But you put together these global ratings by assessing 6 areas, memory, orientation, etc. And these are called boxes. And the sum of boxes is a common and somewhat more sensitive measure. I wanted to tell you that because it's the commonest measure that's being used in these studies. So this is lecanemab from Eisai. They did what I call a jumbo size phase 3 trial with greater than 1,700 participants, and it met the primary endpoint, a 27% decrease in CDR sum of boxes, a 0.45 point difference between drug and placebo. These numbers are very similar to aducanumab, and many of us believe these effect sizes are pretty small. They haven't given us the numbers, but they said they met all their secondary endpoints. And their imaging abnormalities were about 18%, which is way less than the other 2 drugs at the moment. The company has recently announced they're asking for regular FDA approval. Okay, the issues. Amyloid-related imaging abnormalities are the result of removing amyloid probably too fast. And there's edema and there's microhemorrhages. And in aducanumab and in donanemab, sometimes the incidence is as high as 40%. Most of these are purely MRI findings, but a small number have neurologic symptoms. And the rate of persistent symptoms is just, we don't have the numbers. There's a lot of issues about actually doing it. We discussed this with our Hopkins leadership, including Jimmy, last year. No, early this year? Sometime, whenever, it was last year, yeah. Capacity. Right now, you got to have amyloid PET positivity, and it's pretty much hard to do that many PETs and that many MRIs. And you need quarterly MRIs for the first year, and it can easily swamp your system. The original cost of aducanumab was $56,000, and oh, they're so generous, they lowered to $28,000 a year. But there's a lot of costs associated with infusions and MRIs and so forth. The duration of the trial is short. There's another drug, gantenerumab, which is doing a 2.5-year trial. The main thing is the clinical relevance. Aduhelm, aducanumab, reduced the sum of boxes by 0.39 from 1.74, and the change was 0.26 in the placebo group. And they had a strong rate of amyloid removal. Is this a lot or a little? We've been looking into the MCIDs, the minimal clinically important differences for these various measures. And for the CDR sum of boxes, probably the number 1 is a minimum. So we're not near that. And considering the cost and side effects, there are many questions about whether these drugs will be widely used. So keep yourself posted. Look at the headlines, because the FDA is going to start reviewing this in January, and you can expect a lot of publicity on this. A lot of things going on. The best part of the talk is last, and I hope not to hurry too much, but lifestyle strategies. There are a lot of modifiable risk factors for Alzheimer's. A recent Lancet review, which includes my close friend Quincy Samus, associate professor, hopefully full professor soon, suggests that 40% of Alzheimer's risk is due to modifiable risk factors: exercise, depression, vascular risk, hearing, and social engagement. A somewhat different list in some recent US EPI cohorts: midlife obesity, physical inactivity, low educational attainment, and the exact mix really depends on different regions of the world and different ethnicities. Aerobic exercise is associated with lower risk of incident dementia in a lot of EPI cohorts, and sometimes actually with increased hippocampal volume. The mechanism might be vascular or might be inflammation. A recent study called EXERT by our friend Laura Baker, who was our OSOF scholar this year, was comparing aerobic exercise versus stretching, bending, resistance. She found no difference between them, which is disappointing because we thought aerobics would be better. But they did do better than a matched epidemiologic cohort. It's not quite the same as a definitive study, but suggestive that exercise may be helpful. We know depression is a risk factor for dementia, but we haven't proven that treating it will prevent dementia. There's some hints of studies. I'm actually doing finishing up a psychotherapy study with Dimitris Kiosis at Cornell Westchester. Not really more of a treatment than a prevention study. I'm part of Project Costas' PI to do just such a prevention trial for people with mild behavioral impairment. Vascular risk factors, midlife risk factors are associated with late life dementia, including obesity, hypertension, and lipids. Sprint Mind. You guys may have heard of Sprint, because if you go to the doctor is probably trying to get your blood pressure aggressively controlled, if you're old like me, below 120/80. And in that group, this definitely reduced mortality, also decreased the incidence of MCI, didn't quite make significance for dementia, and was associated with increased cerebral blood flow. But this is just one study, and actually there's a number of null studies about using tight blood pressure control. So I would say we think we know what to do for vascular risk factors, but we haven't proven that it works. Hearing is a very promising target. Hearing loss is associated with incident MCI and dementia. We have great leaders in Hopkins ENT. Frank Lim is doing a multi-center trial of hearing aids for prevention. And Yuri Agrawal has found vestibular function in DC, and she's vestibular function in Alzheimer's disease. Until I helped her out with her study, I didn't realize there's well-defined methods of physical therapy for vestibular function. So she's doing a trial of vestibular function. And just to give you an idea of Frank's studies, this is in the Baltimore Longitudinal Study of Aging. And here are people with normal hearing, here are people with severe hearing loss, and we're way out here in the 12 to 15 year range. And the folks with severe hearing loss were much more likely to become demented, like 5 times as likely. Social engagement. There's considerable evidence that having a variety of leisure activities that include socialization is protective against dementia, and a richer social network may be protective as well. Investigator Hiroko Dodge at Oregon. She did a controlled trial of tablet-based conversation. This is a picture she uses of the guy talking on the tablet with a research assistant. Quite a bit, 2 to 4 times a week for 30 minutes. Topics follow naturally. It's not a psychotherapy, and these are not psychotherapists. Boy, she had a hard time doing this during COVID, but she did. And she had 56 completers, and she did see a MoCA improvement, MoCA benefit or MoCA advantage in the intervention group with a very large Cohen's d, 0.73. Of course, it's a moderate Cohen's d, a moderate effect size, but in my world, hardly anything has even that large an effect. And dorsal attention network connectivity was improved in the group that was doing the talking. I've quizzed her. I've asked her a lot of questions about this. I still don't know what they're talking about, but I do know that they're not psychotherapists. Sleep. There's a bidirectional relationship between poor sleep and amyloid deposition. Amyloid's probably cleared during sleep. Amyloid can make sleep worse, and there may be abnormal circadian rhythms. Adam Spira, Mark Wu, and I are using activity and home sleep testing to study sleep and activity through the Alzheimer's spectrum. And this was in cognitively normal older adults who are amyloid positive. And it's something called an FOSR, sophisticated statistical analysis. And it showed that the amyloid positive were more active during the day. And Barry Greenberg, who works with Marilyn Albert in neurology, and I have a RCT about to get in the field of trazodone to target sleep and cognition. There's a lot of work being done on multi-domain interventions, and I'm going to, in the interest of time, have to skip the details of these two. So what's new in Alzheimer's? A lot of work on blood-based biomarkers. I'm proud to say that we at Hopkins are deeply involved with improving treatment for neuropsychiatric symptoms. As I said before, they are like the low-hanging fruit. We may be modifying the disease course by removing amyloid. I personally think these drugs work. Air quotes work. I'm not sure they work well enough to make a difference yet in patients' and families' lives. And our biggest promise is to improve prevention with lifestyle strategies. This isn't even everyone I can thank, but it's everyone I could fit on the page. And I would like to take questions now.
Terrific. Terrific, Paul. Thank you. Great talk. Thanks for leaving lots of time for discussion. Let's see, you want to stop sharing maybe?
You bet.
Well, gosh, there's an awful lot of interesting work there. I want to ask you a question, I suppose, about what you didn't say, and that is on the issue of tau. I guess as you pointed out, I was involved in a little bit of the discussion around aducanumab, and it got me thinking about tau, which I gather many people think is potentially more critical. Why aren't there drugs, or are people working on drugs that can help eliminate or decrease the amount of tau in the brain?
Good point. Tau is our best target now. The reason I did not talk about it is I wanted to talk about what's new, and so far nothing has been stunningly helpful. Tau is it's a twinkle in our eye. Let me be more specific. There's a lot of work being done on anti-tau antibodies. They're generally targeting progressive supranuclear palsy because it's a pure tauopathy. It's a pure tau problem. And I don't know how many, at least 3 anti-tau antibodies have failed. So there's a lot of work being done on small molecule inhibitors, but we ain't there yet.
Okay.
Let me take Ray's question.
Well, tell you what, I want to call on Costas, who has his hand up.
Oh yeah.
Truly tremendous job, Paul. Thank you. Nice way to pull everything together for all of us. I was talking to a CNN reporter earlier today about lecanemab. And one of the questions she asked me that I'm curious to get your response to is whether lecanemab findings confirm the amyloid hypothesis. My first reaction was I'm not even sure what the amyloid hypothesis is right now. But I'm curious to see what you think, and then maybe I'll get a chance to tell you what I think.
I think all these antibodies have reported that if you remove amyloid, you get a cognitive improvement or cognitive advantage, but it's not that much. This is all about effect size. So the amyloid hypothesis is true, but is it true enough? And it really doesn't, it does not feel like these drugs used at this time of the disease are going to have a major effect.
Yeah, I mean, that's why I was questioning what the amyloid hypothesis is, because the original hypothesis went along the lines of amyloid is the cause of all evil. If we get rid of it, the disease will stop progressing.
So let me just mention. So something I didn't have time in 45 minutes to cover the whole field in enough depth. But remember, a substantial proportion of older persons have amyloid in their brain, cognitively normal older persons. And we think they're at risk of getting a disease, but we really don't know it for a fact. We have not proven that these older folks are going to get demented because of amyloid. So I'd say the amyloid hypothesis gets weaker as you get older. And in people over 90, they mostly have amyloid, and it's mostly irrelevant to their cognition.
I just want to point out, though, that aducanumab and lecanemab, everybody on drug is steadily worsening. So if the amyloid hypothesis was about stopping the disease, it has not been supported.
Yep.
Okay, thanks. Cynthia.
Oh, thanks. Thanks, Paul, for the really good review. I know, because you're my study physician, that you know that cortisol and the glucocorticoid receptor is important, and stress and Alzheimer's disease are linked. What you may not know is that every single risk factor in that Lancet paper that you talked about, except for low education, is associated with increased cortisol. So my question is, why is it that stress and that whole, mechanism is completely ignored pretty much in the field of Alzheimer's prevention?
It's mostly because it's hard to study, because people like you haven't done enough widely publicized work on it yet. It's sort of one of those up and coming risk factors. Certainly epidemiologically, it's often found to be a risk factor. It's been hard with stress to define it in a way that makes it easy to study. I think your work is a big part of trying to put this on the map.
Great, thanks, Paul. So back to our chat. Ray DePaulo says, Paul, thanks. This is a great update on the world of progress in Alzheimer's. What about the medication that's been used for a while now, donazepam or Aricept? Where are things with that?
So I titled my talk "What's New," which is why I didn't talk about Aricept, because not much new in that field of drugs. They're called cholinesterase inhibitors. They've got a maddeningly consistent yet modest symptomatic effect. So we use them plenty. We use them. I mean, I use them in just about anyone that I think has Alzheimer's clinically, but I would happily replace them with a better drug if one would come along. And that's because they purely improve your symptoms for a period. They basically give you a lift, and you keep declining. And the difference on the x-axis is 6 months to 12 months. So they buy you some time. It's worth doing, and they may well have as much effect as these antibodies. But there hasn't been much new in that area. Our feeling is the effect is maybe maxed out because it may not be safe to give stronger inhibitors.
Can I follow up, Jimmy?
Sure.
Okay, and that is two things. One is, first off, thanks very much on that answer. That's very helpful. I had one patient that looked like his mini-mental actually went up for about a year and a half, but then fell, as you said. So
our clinical impression is that the responses are idiosyncratic. That's why I try them in everybody. But I don't see response in everybody. What I see is instead some really good responses, and then a lot of null, what are you giving me, placebo, doctor?
All right. By the way, so if I could add a comment though to Costas' in your discussion, because I think it's a good discussion about the amyloid hypothesis. I would agree, Costas, that in a sense, we've disproven it as an absolute path, the pathway to Alzheimer's disease. But I think it was a very useful hypothesis. I wonder if you would agree. for organizing the field. It used to be that you couldn't do an Alzheimer's study, it seemed to me, if you didn't have that pathway as part of your study. And I think that's what helped disprove the hypothesis in a way and led us to better ideas. What do you think?
Yeah, I think you're right. But I think we're also in a period where there's so much devotion to the hypothesis that we get overinterpretation of findings. The very idea that the FDA accepted the lecanemab protocols with a target benefit of 0.4, a CDR point, is an example of that. The field, especially the advocacy groups, are desperate for a big win, and so they're presenting what is at best a lukewarm win as a big win because of the mechanistic concept behind it that we call the amyloid hypothesis.
Great. No, thanks. That's very helpful. That's very helpful to clarify. Yeah.
So let me move on to Tim. Tim Moran's question: where do things stand on the idea of a central insulin insensitivity contributing to Alzheimer's?
Yeah, people like to call it diabetes type 3. Yeah, I mean, something I didn't have time to cover. Thank you for giving me the opportunity. There's a lot of evidence that in Alzheimer's the brain becomes insulin unresponsive, less responsive. You know, the brain is glucose obligate. You can't have anaerobic. The only way to have anaerobic metabolism in your brain is to die. People have been targeting that insulin unresponsiveness. Our friend Suzanne Kraft did a study of intranasal insulin, a study very much marred by the difficulties of administering it. And she used 2 different applicators that you were sniffing the insulin. One of them might have worked. This is a post hoc finding. One of them might have had pretty good effect. And this combines with another finding, the drug Januvia, semaglutide. You know, it's approved for Alzheimer's. It's also approved, by the way, for obesity. Sorry, it's approved for diabetes. It's also approved for obesity. And they're studying it in Alzheimer's, and it's a really a promising new area. So there's a lot of work being done there.
Costa says the comment, this is where precision medicine comes in, since pathways such as stress and insulin and sleep may be major drivers for some people, some subgroups. We need to stop thinking of Alzheimer's as one entity. Makes sense. Lisa Beauvoir says, when we talk about recommending prevention clinical studies for patients, what age range are you enrolling?
Well, prevention studies are really hard to do. They have to be huge, and they have to last a really long time. The one that we're a site for right now, I think we're going to give drug for 4 years. And so you need people who are at high risk, and you can't go too young. If you're doing 50-year-olds, you can't define who's at high risk because they don't have amyloid in their brain. So the one we're doing is 65 and up. But it doesn't mean it doesn't mean prevention won't eventually reach earlier. It's just you can't study it yet in people in their 30s and 40s.
Thanks. Nathan, one of our second-year residents, says, what in the studies on mortality risk with neuroleptic use in Alzheimer's, what were the most common causes of the mortality?
I can very scientifically say we don't know. There's a hint for cerebrovascular mortality, but it just does not jump out strong enough to be sure. We really don't know what they're dying of. And the problem is, by this point, we're 17 years since that first meta-analysis, and you just can't do these studies anymore. And observational studies will not help you. So great question, Nathan, which I knew. We wish I knew.
And Haroon says, great talk, Paul. What's your thought on an association of frailty and incident Alzheimer's?
There's probably a link through neuroinflammation and peripheral inflammation. A lot of work that's being done on frailty in elderly people suggests that it's a wildly increased peripheral inflammation, and I think that could actually correlate with central inflammation in Alzheimer's. Inflammation in Alzheimer's would make a great other Grand Rounds talk. I should do that sometime.
Yeah. Andy Feinberg asks, is exercise still helpful in prevention?
I think so. I think so. What I was presenting you is the sobering difference between epidemiology and clinical trials. And many a ship of hope has foundered on the icebergs of clinical trials. And what we're finding for lifestyle is It's not that we're finding so many null trials. It's that the effect sizes are not very large. I know I sound like a broken record here, but I'm a doctor and I want a sledgehammer and not a rubber hammer. And that's what we're trying to find out, because essentially the lifestyle work's been mostly epi, starting to do some trials, and we haven't yet seen knock your socks off results. So, yep, I still exercise a lot, hoping that it'll prevent my dementia. Sorry, Jimmy, what were we talking about? I lost track.
Well, I was going to go into something else, but there's another question that pops up. Jacqueline Headley, could the symptoms of Alzheimer's be due to inflammation?
So when people talk in the popular press about inflammation, they usually mean in your peripheral, what we in the brain world call the peripheral body, everything but the brain. And so when you eat an anti-inflammatory diet, supposedly anti-inflammatory diet, if there's any science, it's generally something you see in peripheral blood markers. There's lots of neuroinflammation in Alzheimer's and in most neurodegenerative diseases, but it might well be chemically a different mechanism. It's a somewhat different cell type, microglia. And within our precision medicine center, we're actually modeling microglia made from stem cells in order to start developing new drugs.
Great. The thing I was just going to end with was the issue of, I think you said 40% of Alzheimer's or dementia more broadly is thought to be preventable by lifestyle changes. I think
it's thought to be due to modifiable lifestyle factors. What we haven't shown is modifying them actually works that well.
So, but the 40% comes from epidemiologic studies.
Yeah. And among those, hearing and depression are the most prominent.
Say it again. Hearing
and mood disorder are the most prominent in that list.
Okay. So the things, the diet and exercise issues are just less clear cut in your mind.
They account for less of your risk.
Okay.
It's they talk about population attributable fraction, and they account for less of the PAF. Hearing really jumps out as the single. If you had to pick one thing to do, it would be get hearing aids.
Okay, interesting.
Which, by the way, the FDA has recently approved over-the-counter hearing aids, and for a first pass on hearing, you can get them far cheaper than it used to be prescription.
Interesting. Well, we should wrap up. Terrific talk, Paul. Really very informative, and looking forward to continuing to hear about progress when next time you come back.
I thank all of you for your insightful and interesting questions. For me, that was the highlight of the day.
All right. Take care.
Bye-bye.